Okay, so why is a patient coming to me for an MR spine? Most of the time, it is due to a pain which is mostly a lower back pain. Any patient with a low back pain, what are the possible causes? Number one, it is a degenerative or an acquired cause of spinal canal stenosis. There can also be, though rare, a congenital cause of spinal canal stenosis. Other causes which are rare but still possible include neoplasms, trauma, and inflammatory diseases. Very important example, rheumatoid arthritis. So whatever it is, amongst all these causes, the most important cause and the most common cause of a patient with a low back pain is usually acquired degenerative spinal canal stenosis. And here, the symptom is not just a low back pain, but also features of claudication, along with radiculopathy, all this because of a spinal canal stenosis and thus compression on the spinal nerves. And this acquired degenerative cause of spinal canal stenosis, it's not just one disease, it is a combination of disease involving the bones, joints, ligaments, and the disc. Most common vertebral levels involved is lumbar, followed by the cervical levels. Are all patients indicated for MR spine? No. In 2015, ACR had provided with us an appropriateness criteria for diagnostic imaging in a patient with low back pain. What does this ACR appropriateness criteria tell us? They had divided the patients into 7 variants. Variant number 1 is quite common, a patient presenting to you with an acute LBP, plus minus features of radiculopathy, no red flag signs, no prior management. As an initial modality of imaging, is MRI suggested? No. What are the red flag signs? We will discuss about it later on. So in these patients, as we can see, neither a radiograph nor an MRI is suggested immediately. Now we have the second variant of patients. It is a patient with subacute or chronic LBP, again plus minus radiculopathy, no red flags and no prior management as an initial imaging. Again, radiographs or MR, none of them are suggested initially. Let's come to variant 3. Now from here onwards, we have some role of our imaging modalities. Who are these people? They are the people with subacute or chronic LBP plus minus radiculopathy. Now, such a patient who had 6 weeks of optimal medical management and still the patient has persistent or progressive symptoms, and now the patient has been prepared or planned for a surgery or intervention. In these patients, we can do MR lumbar spine immediately. Fourth variant, in those patients who have suspected cauda equina syndrome. In these patients, even at the slightest suspicion, we will do it as an initial imaging. Fifth variant, LBP, and the patient has a history of a prior lumbar surgery plus minus radiculopathy, and now the patient is having new or progressive symptoms. Variant number 6, LBP plus minus radiculopathy, that is there whether it is acute, subacute, chronic. But now one or more of the following is present. Number 1, a low velocity trauma history, osteoporosis, an elderly individual, or history of chronic steroid use. And the last variant, again same, LBP plus minus radiculopathy, one or more of the following present. Number 1, suspicion of cancer, suspicion of infection, and there is a history of immunosuppression, whether by therapy or by disease. We talked about red flag symptoms initially. So red flag symptoms are a group of symptoms which indicate a more complicated case, and hence in these patients, as an initial imaging itself, we are going to suggest an MR spine. These are when we suspect cancer or infection to be the underlying cause of the low back pain. Patient may have a history of cancer, an unexplained weight loss, immunosuppression, urinary infection, IV drug abuse history, prolonged use of corticosteroids, and as we had already discussed, back pain which is not improving with conservative management whenever we suspect spinal trauma and whenever we suspect a cauda equina syndrome or any other severe neurological condition. We have been talking a great deal about acute, subacute, and chronic SBP. What are these actually? How are we defining the time period? Up to 4 weeks, we usually say it's acute. 4 weeks to 12 weeks is subacute. And if it is more than 12 weeks, it is now a chronic LBP. Now, let's move on to the imaging modalities available. We can do an X-ray, we can do CT, we can do MR, but what we will talk about today is an MR scan in these patients. Why we are choosing MRI? These reasons of choosing MRI we all know. Number 1, it is non-invasive, no radiation exposure. Number 3, excellent soft tissue contrast. Number 4, we get a very detailed anatomical delineation of the structures that we want to talk about. And because of all these reasons, it is no doubt that MR spine is the investigation of choice in those people in whom we want to differentiate an objective cause of the radicular symptoms that the patient is having from the normal age-related degenerative changes. So this in front of us is an MR of the lumbar spine. What are the things that we can see here? These are the vertebral bodies. This is our IV disc. This is the spinal canal. This area is the area whose pathologies we are mainly going to discuss. And this area is known as the discovertebral complex, which consists of this IV disc, the vertebra above it, its inferior portion, and the inferior vertebra's superior portion. Here, this is the fat, epidural fat. How does each structure look like in T1 and in T2? T1 is best for osseous anatomy and provides an excellent contrast between the epidural fat and the intracanal contents. See, because in T2, see, this is a picture of T2 lumbar spine. The color of this thecal sacs CSF, color of the epidural fat is almost the same. So between these two, differentiation is difficult. But here we can see that in T1, CSF intensity is hypo, it is low intensity, therefore it provides an excellent contrast between the fat and the intracanal contents. How does the vertebral body look like? This is the cortical portion of the vertebral body. The cortical portion of the vertebral body is hypointense in both T1 as well as in T2. In comparison to the cortex, the marrow of the vertebral body is slightly hyperintense in both T1 as well as in T2. How does the nucleus pulposus look like? A very important thing to remember about the nucleus pulposus, see the intervertebral disc, if you see it from above in axial section, it consists of two types of tissues. Inside we have the nucleus pulposus. Outside we have the annulus fibrosus. Importance is nucleus pulposus is rich in glycosaminoglycans. What is the important thing that we know about these glycosaminoglycans? Is that they attract water molecules. This is important because the nucleus pulposus is filled with water and it helps to transmit the axial load that is coming from the body, helps to distribute this axial load radially like this. That is why the water content is necessary, and because of the water content we get its typical MRI visualization. Just like water, in T1 the inside, that is the nucleus pulposus, is slightly hypointense. If you compare it with the hyperintensity that you see in the nucleus pulposus in T2, because water in T2 is bright, we know. And annulus fibrosus is made up of what? Fibers. It is fibrous content, and we know fibrous content is very lacking in water. It appears hypo in both T1 as well as T2. This is the annulus fibrosus here, appearing hypo. Again the annulus fibrosus, appearing hypo. Then we have the ligaments. The anterior longitudinal ligament, ALL, which is again hypo in both the sequences, in T1 as well as in T2. This is the ALL, sorry. Posterior longitudinal ligament likewise is also hypo in both T1 as well as T2. Okay. I'm removing all this so you can see it well. Okay. Now let's move on. Let's delve deeper into the anatomy of the lumbar spine. Okay, so this is an axial image of T2. This is the IV disc. As we have seen, this is the nucleus pulposus, which is hyperintense in T2. This is the annulus fibrosus, which is hypointense in T2. This is our central canal. These are all the nerve roots that you can see. In the central canal, the nerve root that is present lateralmost. The lateralmost nerve root is the traversing nerve root. And this, if you see, is the neural foramina. The nerve that is present within the neural foramina. This is the exiting nerve root. These traversing nerve roots are traversing through a space called the lateral recess, which is present in the anteromedial aspect of the pedicles. One more thing that we can see here is this epidural fat is present everywhere. Surrounding the central canal it is present. Surrounding the neural foramina it is present. Okay, so it is filling up the neural foramina, it is filling up the thecal sac, and even it is surrounding the exiting nerve roots. Very important anatomy that you should learn here is the facet joints. These are the facet joints that are present. Let's move on. So this is a 3D reconstruction of our lumbar spine. Before talking any further about the lumbar spine, we should know that each lumbar spine has this 3 joint functional unit. Each of them have this 3 joint functional unit. What is this 3 joint functional unit made up of? The end plate IV disc end plate complex. Number 2, the paired zygapophyseal joint. The name looks tough, but this joint has a better name. We all know it by its name, facet joint. As we can see here, IV disc, end plate complex, and the facet joint, which is not very visible from here. I'll show it to you from some other angle. Now we'll talk about how this lumbar discovertebral complex, they are divided into 3 columns: anterior column, middle column, and the posterior column. If you divide the vertebral bodies into half, this is one column. Everything anterior to it is the anterior column. Anterior column, we have anterior one half of the vertebral bodies. We have anterior one half of the intervertebral disc, and we have the anterior longitudinal ligament. Let's draw the anterior longitudinal ligament here. It is present somewhat like this. The posterior longitudinal ligament is present somehow like this. So what does the anterior column consist of? Anterior half of intervertebral body, anterior half of the disc, and the ALM. Middle column made up of rest of the things that we have not mentioned in the anterior. posterior half of the vertebral body, posterior half of the intervertebral disc, and the posterior longitudinal ligament. So this is the middle column. Now the last one, the posterior column, consists of the pedicles, facet joints, lamina, the spinous processes, the ligamentum flavum, and the interspinous ligament. All of this entire portion here will make up our posterior column. Okay. We will talk more about each of these structures. Let's move on. This is the pedicle that we had talked about earlier. These are the pedicles. Over the pedicle, this space where the traversing nerve root is passing is the lateral recess somewhere here. Okay, this is the facet joint, as we can see. This facet joint is formed by this superior articular process. This superior articular process is coming from the inferior vertebra of that discovertebral complex. And this is the inferior articular process. Inferior articular process is coming from the superior vertebra of that in discovertebral complex, and the synovial joint that is formed in between them. This is our zygoapophyseal joint or the facet joint, and it comes under the posterior column. Here also we can divide. Till this is the anterior column, till here is the middle column, and behind this everything else is the posterior column structures. Here this portion is the lamina, then the spinous process. Surrounding the spinal canal, here we will find the ligamentum flavum. This is the vertebra, axially how we see it. These are the superior articular processes. We should know that the superior articular processes, they are directed posteromedially, and the inferior articular process will be directed, as we can see here, will be directed anterolaterally. As we can see here, they will be directed anterolaterally. These are directed posteromedially, and these will be directed anterolaterally. Yes, here we can see the neural foramen. This is not exactly sagittal view, parasagittal view. This is a vertically oval shaped structure, or you can say a keyhole shaped structure, whose superior aspect the nerve root is exiting, and the rest of it is surrounded by fat again. This is our neural foramen. And what are the boundaries of the neural foramen? As we can see very clearly, superiorly and inferiorly, we have the pedicles of the superior vertebra and inferior vertebra. Anteriorly, we have the vertebral body in front, the IV disc, and again this inferior vertebral body in front. Posteriorly, we have the facet joints. Facet joints are true synovial joints, and they are lined by hyaline cartilages. One more thing here that we should know, is what is the pars interarticularis. Yes, we have a picture. So this is the superior interarticular facet, inferior articular facet, and the region in between the two articular facets, this region is the pars interarticularis. What is this structure? This is the pedicle. And we had already said that the superior articular facets, they will face posteromedially, and the inferior articular facets, they are going to face anterolaterally. Let's talk about the ligamentous structures that we have in the posterior complex, which are together known as the posterior ligamentous complex. We have number 1, ligamentum flavum, which is the most important structure. We have interspinous ligament. We have the supraspinous ligament. Also, along with all these, the facet joint capsules are also considered to be a part of this posterior ligamentous complex. Let's see a schematic diagram. This is the ligamentum flavum. The ligamentum flavum connects what with what? Connects the two lamina, or in other words we can say the ligamentum flavum bridges the interlaminar interval. This ligamentum flavum medially, it is attached with the interspinous ligament. It is not very evident in this picture, but from other views when you see, you can visualize. Medially they are attached to the interspinous ligament, and laterally they are attached to the facet joint capsules. So this lateral attachment you can see here, laterally they are attached to the facet joint capsules. The interspinous ligaments are the ones that connect the spinous processes, and the supraspinous ligament is the one that connects the apices of the spinous processes. Next, let's move on to the imaging. Again, let's see the imaging normal anatomy. Okay. This is which sequence? Obviously, here you can see that the central canal CSF is hyperintense. This is definitely a T2. Okay. So this is the intervertebral disc. In the intervertebral disc, this inner hyperintense portion is the nucleus pulposus. The outer hypointense portion is the annulus fibrosus. This black structure, very hypointense structure, is the anterior longitudinal ligament, and this very hypointense structure is the posterior longitudinal ligament. Here if you see, this is the epidural fat. Behind the epidural fat, this very hypointense structure, again this very hypointense structure, these are the ligamentum flavum. In between the spinous processes, we have the interspinous ligament, and connecting the apex of the spinous processes, we have the supraspinous ligaments. Okay, let me rub it off so that you can have a better visualization. Another picture, which is a slightly parasagittal image. Again, this portion is the ligamentum flavum. This is the ligamentum flavum. This is the spinal cord in the central canal. This is the CSF that is present in the central canal. Intervertebral disc. White portion of the, or hyperintense portion of the intervertebral disc is the nucleus pulposus. This is the annulus fibrosus. ALN, PLN we have already discussed. Now we will talk about the pathological findings. We will talk about this entire process that happens with aging. there are certain things that you will find only in normal aging and not in pathologic. And then there are certain overlapping things also that is seen in early disc degeneration as well as in normal aging. As we have already discussed earlier, this is the intervertebral disc. We have the nucleus pulposus. The nucleus pulposus is rich in glycosaminoglycans. As a result of which, they will trap a lot of water, and this water is required so as to transmit the axial weight of the body in a radial direction so that it is equally transmitted and we can bear the weight. With aging and with degeneration, what happens is the amount of these glycosaminoglycans, they will fall. As a result, the water levels also fall. Thus, we say that the disc becomes dry, or in other words, there is disc desiccation. That is our first thing that happens. How will we visualize this disc desiccation? I have told you that the nucleus pulposus appears hyperintense on T2. Why? Because it contains a lot of water, but now because of the lack of water, it will appear hypointense. Because of this, what happens now? The disc is not able to radially transmit equally the weight of the axial force. Now what it does is, preferentially, if this is anterior, this is posterior, preferentially it will transmit most of the loads posteriorly. Because of posterior transmission of most of the loads, there will be stretching of the fibers of the annulus fibrosus. And because of this, there will be tears in the annulus fibrosus, which are named as fissures. Annular fissures. This is the second thing that is going to happen. How will the annular fissures look like? Because of tear in the annulus fibrosus, water is entering here. Or maybe granulation tissue is entering. So they will appear hyperintense on T2, T2 bright. One more important thing is, these things may also undergo enhancement with gadolinium. Next, are these mechanical disruptions enough to cause pain? No. A very important cause of the pain that the patient is facing in these cases is the inflammatory processes that go on. Let's talk about that inflammatory processes that go on here. Because of increased mechanical stimulation of the pain receptors that are present in the annulus fibrosus, there is this inflammatory response mainly mediated by TNF alpha. So this presence of this inflammatory exudates, inflammatory processes that go on, are a very important reason for the pain that is happening. And that explains the reason why the pain may persist in some patients even after surgical decompression. This also explains why sometimes, despite there being a very large disc herniation, still there is no pain. This explains why just with conservative management, many of the patients are cured, and therefore in those patients who had acute or subacute, as we had studied in the ACR appropriateness criteria, we suggest few weeks of medical management. Also, this is the reason why the severity is not dependent on the size or shape of the herniation. Let's move on. We have the spectrum of things that are together known as degenerative disc diseases. They can be a result of normal aging processes and are not considered pathological. They can be pathological. Whatever we talked about in those, disc desiccation can be both a feature of normal aging as well as early feature of pathological degeneration. Along with that, there can be presence of anterior and lateral osteophytes, which are of the marginal type. And there is no substantial disc height loss. All these are together termed as spondylosis. Though this term is often used interchangeably with all the spectrum of these degenerative disc diseases, but literally speaking, spondylosis refers only to the normal age-related changes and not the pathological age-related changes. Now, what are the things that we consider pathological? Any reduction in the disc space height, presence of any posterior osteophytes, radial annular fissures, end plate erosions, marrow changes, nitrogen gas within the nucleus pulposus. All of these, this entire thing represent a cascade of pathological changes which have been together termed as intervertebral osteochondrosis. So we know that osteophytes are very common finding. Osteophytes are nothing but new bone formation from the bones that are already present. Why does these form in normal age-related degenerative diseases? Because we already know that due to disc desiccation, there is only transmission of the weight of the body posteriorly. So there is this disbalanced transmission to take up the load of the body and increase the surface area. They create additional articular surfaces by forming osteophytes. Now let's move on to the flowchart that we were already discussing about. As we know, what was happening then is there was preferential distribution of the weight posteriorly, because of which there were fissures in the annulus fibrosus, osteophyte formation, and finally the posterior column structures, they get affected. Amongst them, very important structure to get affected are the facet joints. There is thinning of the facet joint, there is erosion of the articular cartilages, there is joint space narrowing, there is subchondral sclerosis, there is synovitis, osteophyte formation, synovial cyst formation, all the things that happen in osteoarthrosis. So basically, we have facet joint arthrosis. Finally, leading on to facet hypertrophy. All these things will lead to stenosis of the central canal, which caused all the symptoms that we were having. Not just the central canal, this denotes the neural foramina also, as well as the lateral recess. Next thing that will happen is now the facet joint is involved. Now ligamentum flavum will now get affected, and there is hypertrophy, there is laxity, and there is anterior buckling of the ligamentum flavum. All these things again finally lead to a spinal canal stenosis. The interspinous ligaments are also getting affected. The supraspinous ligaments will also get affected. All of these finally lead to this common ending, that is central canal stenosis. Two other things that I should explain to you is spondylolysis, where there is pars defect, and spondylolisthesis, there is pars defect, and because of this there will be slippage of the vertebral body with respect to the adjacent vertebral body. The term that we talked about earlier as a normal age-related changes that occur in the spine is spondylosis. Okay. So what are the findings that we are getting in this image? Firstly, which sequence is this? This is definitely a T2 sequence because the CSF is bright. Here then let's look at the intervertebral disc. Okay, the central portion is bright, the central portion is bright. Where is the brightness in the central portion? So this is definitely disc desiccation. This is definitely a dehydrated disc. What is this? This is the hyperintensity in the annulus fibrosus. These are nothing but annular fissures, or you can say disc disruptions. Okay. Anything else? Yes, we have another picture. Here we have disc desiccation at this level, disc desiccation at this level. Not just that, there is disc herniation also. But what is the important thing we should know? This is the hyperintense area in the annulus, which has been bulged or herniated. That obviously we will understand only by its axial views. But here what we see is an annular fissure. Okay, next image. Okay, again the nucleus pulposus is this, but it is hypointense here. So this is definitely disc desiccation. What is this hyperintensity in the annular fibrosis? This is annular fissures. Fissure. Okay, next. Okay. This we talked about the facet joint osteoarthrosis. This is the facet arthrosis that we have, along with its hypertrophy. Where is the ligamentum flavum? This is the ligamentum flavum. This is the facet joint. Is the ligamentum flavum hypertrophied? We might know if we measure it. What is the cutoff? 4 mm is the cutoff for ligamentum flavum hypertrophy in lumbar spine. What is the cutoff for ligamentum flavum hypertrophy in the cervical spine? Comment below. I told you about ligamentum flavum hypertrophy. This is a very good case of ligamentum. We don't even need to measure. This is the ligamentum flavum. This is the ligamentum flavum, and at this point it is truly hypertrophy. We'll see an axial section. See, this is the ligamentum flavum which has hypertrophy, and what it has done to the central canal, it is stenosed. This is suppose another vertebral body. This is the intervertebral disc in between them. There are certain changes not in the disc but in the that happen in the end plate of the vertebral body that affect these portions of the vertebral body. Okay. These are modic changes named by Dr. Modic and his colleagues who first described it. These are signal changes in the vertebral subchondral bone marrow, in the vertebral end plates because of nuclear degradation and a continuous end plate articular cartilage disruption. Mostly these changes are inflammatory in nature. We have divided these modic changes into three: modic 1, modic 2 and modic 3. What happens in modic 1 is, this is considered to be the active inflammatory stage. Modic 2 is considered to be the dormant phase, and modic 3 is post-inflammatory. Because the type 1 is active inflammatory state, therefore the patient will have high levels of C-reactive protein. And which is the most common type here? Type 2 is most common. Second most common is type 1. And what is third most common? 1 plus 2 overlap. Chalo. What is happening is, in type 1 there is a subchondral bone marrow edema. Because of this, and this will be visualized as T2 bright and T1 low intensity. What is actually happening? There is disruption and fissuring involving the end plates, because of which the marrow, the subchondral vertebral bone marrow, is infiltrated with a fibrovascular granulation tissue. Because of this reason, in contrast enhanced images, there is enhancement. Okay. Let's come to type 2. In type 2, there is infiltration of the subchondral bone marrow with yellow fatty marrow instead of red. Yellow fatty marrow. Why? Because the red marrow is replaced due to ischemia. Marrow means what? Marrow means fat. So how it will appear? T1 also bright, T2 also bright. Next, the third type, or the post-inflammatory type, the main pathology is there is a subchondral end plate sclerosis. As a result, there is increased fibrous tissue present, and because of this reason, it is hypo in T1 and it is hypo in T2 as well. Let's see some pictures. What is this? Here you can see at the region of the end plate, there is some hypointensity. See, there is some hypointensities, and this is T1. Yes, this is the T2 image of the same patient. In the same region, this was the region here, and this is the region here. In the same region, it is T2 hyperintense. So T1 here is hypo and T2 is hyper. So which one is it? T1 hypo, T2 hyper. This is therefore type 1, or the active inflammatory type. The next, here you can see some changes in the end plates. You can see some changes. This is T1, CSF is hypo. This is T1. So in T1 there are some hyperintense lesions at the end plates. This is T2. You can see from the CSF. Again, in the same place, we have the same hyperintense lesions only. So we have lesions here which are hyperintense in both T1 and T2. Let's see. T1, T2 both hyperintense. This is Modic type 2. The last one. Very bad condition. Extremely reduced disc height, disc desiccation. Okay. So here we can see some changes. Here we can see some changes. Some hypointensities. Here some hypointensities. Some hypointensities. The same place if you see in the this is T1. This is T1. The same thing if you see in T2. Again hypointense, hypointense, hypointense. So T1 hypo, T2 hypo. Only one is left. This is the type 3. So these are the modic changes that we talked about. And these are the images that we discussed. Next, what are we going to study? Okay, some nomenclatures. Whenever they say high intensity zones, whenever they say high intensity zones in the intervertebral disc complex, already we have studied this can be due to the IV disc disruption, that was our annular fissures. That can be a cause. Another cause is presence of trapped nuclear material within the periphery of annulus fibrosus. Next, let's talk about the disc herniation nomenclature. Very, very important. Whenever there is an abnormal disc contour where the annulus fibrosus has extended beyond the margins of the vertebral body by more than 50% of its circumference. This is not a herniation. This is disc bulge or generalized disc displacement. On the other hand, anything like this less than 50% is disc herniation. This is disc herniation. See here, these are the normal margins of the annulus fibrosus. Normal margins of the annulus fibrosus, and here annulus fibrosus is extended beyond the margins of the vertebral body, almost the entire of it, at least more than 50%. So this is a generalized disc bulge or a generalized disc displacement and not a herniation. Here we see that only a small part of the annulus fibrosus has extended beyond the circumference of the vertebral body, and this is our disc herniation. Now these disc herniations are of several types. I told you that if it is if it involves less than 50%, it is herniation. If it is less than 50% but more than 25%, then it is called a broad-based herniation. If it is less than 25%, it is called a focal herniation. Okay. Another differentiation is extrusion, protrusion. This is the herniation, suppose. This is one herniation. Okay, once more. This is one herniation. And this is one herniation. In both of this, we can see that less than 50% of the circumference is involved. But what is the stark difference between both of these? In here, picture A, this is picture B. In picture A, I see that the diameter of the base is the smallest diameter of the herniation. All other diameters, including this, is larger. If the base is suppose X and this is Y, X is always the smallest. X is smaller than Y. This is called extrusion. The name also suggests that the disc has extruded out, thrown away. So this distance is much more. Here, the complete opposite. The diameter at the base is the widest than any other diameter. If this is X dashed and this is Y dashed, then by seeing only, we can make out that X dashed is bigger than Y dashed. This is protrusion. It has not thrown it away a lot, but just protruded. So this dimension is lesser. So this is our protrusion. This is clear. Next, let's move on to some schematic diagrams. Again, here the base is wider. Then other dimension, this is protrusion. The base is the narrowest. Again, this is extrusion. Chalo. Here we have real images. What do you see here? Let's measure. We won't be able to exactly measure, but still, let's guess. This is the base. This is a bulge or herniation. This is definitely a herniation. Amongst herniation, is it a focal herniation or a broad-based herniation? If this is 50%, half of this should be 25%. Is it involving half of it? More? Is it involving more than 25%? No. So this is definitely a focal herniation. Let's measure. This is the base and this is the other dimension. So more or less we can find out that X, the base is X, this one is Y. Y is greater than X. This is throwing it out. This is extrusion. Location, slightly paracentral. Okay. Move on to here. This though we can find out by just seeing it. This is entire thing is the base. And this is the other dimension. X dashed, Y dashed. X dashed is definitely bigger than Y dashed. This is not throwing it out so much, but a little outpouching. This is protrusion. Next. Okay, so localization. How do we localize? We draw 3 lines on each side. Number 1 is between the medial margins of the facet joint. These are the facet joints. So first line is between the medial margins of the facet joints on both sides. This is the medial margins. Okay. So here we are joining the medial margins of facet. Next line we will be drawing medial pedicle margin. So this is the pedicle. This is the pedicle, right? So this will be the medial pedicle margin. This is going to be the medial pedicle margin. This entire thing is the pedicle. This entire thing is the pedicle. This is the medial pedicle margin. This is the lateral pedicle margin. Next line is at the medial pedicle margins. So here. Again here. So this extent is the medial pedicle margin. The next line we will draw is the lateral pedicle margin. Okay. So we drew another line along the lateral pedicle margin. So this line is lateral pedicle margins. What are the regions that we got? Let's mark it. This region is the central zone because we marked it in red. This region is the central zone between the medial margins of the facet. between the medial margins of the facet till the medial margins of the pedicle. This zone is the lateral recess zone, also called the subarticular zone. This zone and this zone. Okay. Between the medial pedicle margin to lateral pedicle margin, between the medial pedicle margin and the lateral pedicle margin, this zone is the foraminal zone. This zone is the foraminal zone. Next, lateral to the lateral pedicle margins. Lateral to the lateral pedicle margin, these zones. These zones are the extraforaminal zones. Okay. Again, let's revise. This area between the medial facet joints, this area is our central zone. This area between the medial margins of the facet and the medial pedicle margin, this zone, these zones here, these are the subarticular zone, also called the lateral recess. Now this zone between the medial pedicle margin and the lateral pedicle margin, this zone is the foraminal zone. Foraminal zone. And finally, lateral to the lateral pedicle margin, lateral to the lateral pedicle margins, these zones are known as the extraforaminal zone. So these nomenclatures are required whenever we are describing a herniation, whether it is an extrusion or a protrusion. The location from where it is arising is very important. Okay. Next, we will be talking about certain other variants of herniation. Number 1, whenever the herniation has migrated or has displaced either caudally or cranially, whether or not it is contiguous with its mother disc or not, that is not important. It may or may not be continuous with the mother disc, but it has now got displaced either caudally or cranially. This is known as migration. In this case, it is a cranial migration. So this is migration. Now the herniated portion has lost its continuity with the mother disc, and this is known as sequestration. Here you see, this is a variant of herniation where instead of the bulge being posteriorly, it is now, this is known as intravertebral herniation. Another name, Schmall's nodes. What is the actual pronunciation? If someone knows, please comment. Herniation of the disc material in the direction of the vertebra through, maybe there was a defect in the level of the vertebral end plates. What are the MRI pictures? How will they look like? What is this you can see? Here we have a herniation, definitely. Most probably, sir, because the length is so big, most probably it is an extrusion. Has it maintained continuity with the mother intervertebral disc? Yes, the continuity is present, but it has got displaced. It is no longer present exactly at, suppose this is L5 and S1. This protruded or extruded disc is no longer at the level of L5-S1. It lies behind the level of the S1 vertebra. So this is what? This is migration. What kind of migration? downwards, caudal migration. Let's come to the next picture. Here I can see that we have this portion whose imaging features are same as the disc present here. But the problem is there is loss of contiguity. What is this? This is a sequestration. If this is L5 and this is S1, it's a sequestration. First of all, though, it has detached itself from the IV disc, its own IV disc. Secondly, it has also migrated downwards. It is no longer now present at the L5 S1 level. It is present at the level of S1 vertebral body as well as the S1 S2 intervertebral disc level. So this is sequestration plus migration, caudal migration. What is this? Very important. Protrusion within vertebral body at the end plate. This is Schmall's nodes. Okay. Let me delete. See, these are the small nodes. This is the disc. Sequestration because it has lost its continuity as well as migration. And this is simply disc migration. I was not maybe able to complete it extensively, but I have tried to include as much as possible the things that are required. To summarize, what are the things that we had discussed so far? Number 1, symptoms. What were the symptoms? The patient can be asymptomatic. The patient can have a low back pain, an intermittent claudication with radiculopathy. Sometimes the symptoms can also be very non-specific. When is MRI indicated? We have discussed in a patient with a simple acute, subacute low back pain with or without radiculopathy. We do an initial medical conservative management. Why? That also we know, because inflammatory processes are much responsible for the symptoms than the mechanical disruptions themselves. Therefore, conservative management is very much helpful in reducing the symptoms. And if the symptoms are reduced, what is the need of these advanced imaging? So, initially MRI is not required. It is required in all those variants where we suspect a more serious underlying cause, like a cauda equina syndrome, like an underlying spinal fracture maybe, and in a patient where medical therapy has been done and now again there is a new progressive or persistent symptoms, in a patient who had a previous history of lumbar surgery and now presenting with new progressive symptoms. In all those cases, we will do MRI straight away. Why we prefer MRI, we already discussed, because it gives us a very detailed anatomical delineation of all the structures and very excellent contrast between the structures. So of course MRI is preferred, also because it does not have any radiation exposure involved. It is non-invasive. Okay. We have also discussed about the anatomy of the LS spine, the discovertebral complexes, the ligaments, the facet joint, the pedicles, how the nerve roots are exiting, what is an exiting nerve root, what is a traversing nerve root, all those things we have discussed, and all the findings that indicate the presence of a normal aging related degeneration. They are literally termed as spondylosis, but frankly speaking, spondylosis in daily usage, it is used for all the spectrum of findings that we get even in pathological degenerative diseases. So what is included in a normal aging? Disc desiccation is included, presence of anterior and lateral osteophytes are included, and what should not be present? Reduction in disc height significantly should not be present. If present, we should always consider it pathological. We have also discussed what are the pathological changes, and those cascade of findings were termed as intervertebral disc osteochondrosis, What were those? Presence of any reduction in the disc spaces, presence of posterior osteophytes, presence of radial annular fissures, any end plate erosions, sclerosis, marrow changes, any gas within the nucleus. All of these, they are always and always pathological and are given this broad term of intervertebral disc osteochondrosis. Two important differences: spondylolysis versus spondylolisthesis. Spondylolysis, there is a pars defect, maybe a fracture, but alignment is okay of the vertebral bodies. In spondylolisthesis, due to a pars defect, now there is a slippage of one vertebral body over the adjacent vertebral body. These are the two terms which are often confused. So I'll end my lecture here. If I have missed out anything, please kindly let me know. I will be more than happy to discuss it in my next video. Thank you.